Actually,
Good morning.
I'm from Kerala doing a live case now. We'll just show the case directly because actually we have crossed some. We wanted to show everything, but we could. We were thinking that you come back at 8:15, so we started a little early. So can you just show the
slides? Yeah. Good evening to all. Our patient is a 52-year-old male. Next slide. Next slide, please.
Next.
Yeah, he's a 52-year-old male who had a recent inferior MI. He underwent angiogram elsewhere, which showed a LAD CTO and an RCA 99% lesion, and subsequently underwent a primary PCA to the RCA with 3.5 into 24 tests. And they had attempted PCA to the LAD in that same sitting, but it was they failed. And so now the patient is being admitted for reattempt CTO PCI. Next slide. So this is the ECG. ECG, we can see that the R waves are preserved in the LAD, in the anterior leads, and there is some ERS pattern in the ECG. Next, his echo showed some RWA in the anterior wall, but the thickness was preserved and there was no scarring. The EF is 50%. Next slide. His hemoglobin is normal, 14.1. Creatinine also normal. EGFR is also normal. Next, this is the angiogram. Angiogram, here we can see the initial shot. We can see the LMCA and the circumflex are disease free, whereas the LAD is totally occluded. We can see a small branch, probably the diagonal coming there. And the LAO-caudal, we are not able to see the proximal cap properly. It's not clearly visualized in the angiogram. Next. This is the RCA intervention which he underwent outside. You can see that there is a tight lesion which was stented, directly stented with a good TIMI3 flow distally. Next slide. You can see the final check angiogram of the RCA showing very good collaterals to the distal LAD, and LAD is fairly disease-free. Based upon the angiogram, we have a CTO of the LAD with probably a short CTO with the ambiguous proximal cap. It is a reattempt, so the JCTO score is 2.
Now today's angiogram will show you Sanjog and excellent collaterals from the antegrade. Can you just show the angiogram today?
So this is a
yeah, but we were thinking that we will be just doing an retrograde CTO intervention and demonstrate that. But you can see that minimal flow from the antegrade as well as the retrograde is excellent.
It looks like there's a connection there.
Excellent connection. So we actually took a right coronary right catheter. Can you just show that? So excellent connections. So next shot. Excellent connections and multiple collaterals. You know, Sanjog, actually it can create problem also. At the same time, it is an excellent connection. Almost all the connections are collateral CC3 or CC2 minimum. So we just took a wire. Actually, I took a Caravel with a filled FC wire. Probably the approach will be different. Actually, that was not the vessel I was just looking for. That's not the connection I was looking for, actually. No, that is not.
And so you chose an upfront retrograde approach here.
Actually, I was thinking that will be because in the teaching program we thought one of the retrograde cases to be shown. That is why I was thinking that probably I could have gone antegrade also, but this was not the vessel, but actually just a little distal part is the ideal collateral. So I went here. I just entered the right track. To my surprise, the wire went very fast to the upper branch. That is to the LAD. To my surprise as well as to my luck.
And the wire that
we actually planned to do
wire that you chose?
The cyan black was the plan to wire, but actually it's taken a filter FC only. We did not change the wire, but it has gone easily. My plan was to take a cyan black. Usually my wires are cyan black, Suho 3 and XTR are the wire for septal channel crossing. So it is Caravel gone easily up.
And just as you show the pictures, can you comment on your technique to bring the Caravel through the septum? Are you gently pushing it? Do you spin it? Do you do a combination of both?
No, Sanjog, actually I will take the wire into one of the major septal artery down or a diagonal artery down and then take that. But luckily the wire gone down, so I was not having any difficulty. Can you show the next one?
That's an important point to make, is that this is not a microcatheter that's meant to be spun, and the tip will break if you spin it.
Yeah. So next, this actually gone. Now the septal collateral, I saw that, just did a check. Till now I am not doing any check to avoid unnecessary contrast usage. So next, so this I was checking, then I understood that I can push the wire, and now I saw there is only a little movement. Next, this is the first check I did. I made a different deflection of the wire. Because I know that the wire should bend, and now the wire went in. Next, so I just checked whether I am in the right place or not. Yes. Now I came back. Next. So this is the place I just went. I understood I am in the LMCA because it's roomy LMCA. So I did not take any antegrade wire till now because there was no need of anything. Now I understood it's a roomy one. I made some changes in my wire positioning and the catheter. I think next, same thing.
Yeah.
Oh, it was a long fluoro store. I understood I have to check. I can even put the wire into the circumflex artery and take the microcatheter down. That is also a possibility. I put the microcatheter down and then push the Caravel moat antegrade. Then I took the wire into the direction which I wanted. Sanjo, can you see us?
Yeah, we can see you.
I'm actually sorry that the connections are
Dimitri,
totally gone,
myself, and the entire panel
please,
are here.
please. This was the position we left. Actually, the wire is going inside. Can you see?
Yep, we can see it.
Okay.
We were discussing the strategy that was used when the audio went out.
No, this is actually the next one, I think. This is the wire which actually went inside, and we just kept the microcatheter as possible as, I think next we cross. Next. We crossed in this one? No.
So as you did this, any thoughts about putting a safety wire down the circ and or using a guide extension catheter towards the osseous LAD?
No, this is actually when we crossed, and then we did a balloon dilatation, trapped, and then next is actually we took the microcatheter is inside, naturally as normal retrograde intervention. Then we put a wire inside, that is actually the RG3 wire. Next, we escalated the wire. After that, we kept the microcatheter. It's actually almost at the septal mid part, so that we wanted to check tomorrow any problem is there. Then we did a balloon dilatation, keeping a wire in the circumflex. After balloon dilatation, we did next. We actually saw the vessel is actually having a competitive flow from the other side. Then we put an antegrade wire. The same wire from the circumflex we have taken, one more wire by the time. Next, we took IVUS. This is IVUS. Can you just show the IVUS? IVUS, can you show? Okay. Stalin, explain.
IVUS, we can see the distal LAD is almost like a 2.25 with very minimal plaque.
Probably underfilled.
Yeah. Now we can see some significant disease over there. Fibrofatty, mixed plaque, some amount of calcium we can see at around 3 o'clock, 2 o'clock. Now again the calcium is increasing. You can see here it's almost 1 quadrant of calcium, 2 quadrants of calcium. And again back we have a significant disease over here. Now the vessel is looking almost like a 3O. We have almost a 180-degree calcific nodule protruding into the lumen. And I think this is a part of the CTO. CTO is almost like fibrocalcific CTO, long standing CTO. Can see some minimal dissections probably because of the balloon dilatation or maybe because of the previous intervention, we don't know. Yeah, again it's a mixed fibrocalcific plaque extending almost, we are almost reaching near the osteoproximal part. Yeah, here the vessel looks like almost like 3.5.
3.5, and distally the vessel is only 2.75.
Yeah,
and we
plaque is extending. We can see here the
almost
ostium.
Up to the ostium. This is
you can see the circumflex coming from the 6 o'clock to 8 o'clock position. LMC is disease free.
Totally free of disease.
Looks like a 4.25 vessel. Yeah.
So the next shot, can you just show? We decided to take a cutting balloon. We removed the total left system. We actually checked an injection to see that the septal collaterals are okay. Then we kept the microcatheter in the septum. That is actually the way to be done because we don't want to damage that till everything is out. Then we removed the septals, the right system. Then we actually took an injection and see, because of the calcium and the nearly 180-degree calcium, we decided to take a cutting balloon. We took a Wolverine 2.5 because the distal vessel is only 2.75. We don't want to take a 3 or 3.5 because it is a distal vessel is only 2.75. We took a cutting balloon. Next. This is actually the position we are now. We are actually doing a cutting balloon. Actually, Sanjog, you can make comments.
So I was going to ask you actually, and Dimitri, please let me bounce this off of you. Do you routinely, once you've crossed and externalized, take a dual lumen catheter and flip antegrade, get rid of your retrograde gear? Or do you generally do your work on your externalized wire?
Usually we can actually, I do like a dual lumen catheter like Crusade and all. Here actually I was very much almost sure that I can pass with a single wire without even an extra double lumen catheter. The way I do usually take a double lumen catheter, then keep the wire and take the wire into the antegrade, especially to the LAD easily.
Sure.
But here, actually Sanjog, you can see that you can also pass the wire easily here.
Sure.
So actually,
I guess the point I'm making is, do you flip antegrade or do you work on your retrograde gear?
Yeah.
I think it depends upon several factors. Sanjog, one is how well the retrograde gear is tolerated by the patient. Second is, do you really own the vessel, or how close to the distal cap you are? And then if you're dealing with a bifurcation. So you can finish your case, most of your cases on the externalized wire, because it gives you the best support.
No, usually,
but if you have issues with ischemia or bifurcations or things like that, then I use routinely a dual lumen catheter in exchange for an antegrade.
Yeah, Dimitri, only point actually I just wanted to stress is actually if you have a vessel lumen which is underfilled distal to the entry of the septal collaterals, then you require a wire go to the antegrade. Otherwise you can finish everything by the, if the retrograde, the septal collateral was distally and the vessel disease was totally in the proximal part of the collateral, that is RG3, then everything we usually finish with one wire and we don't take another wire here. And naturally in this case we require definitely a wire into the circumflex. That you agree with that? Correct?
Why do you think that the flow in the distal LAD is a little bit suboptimal?
That is basically because you have an excellent collateral coming from the right system. So as long as the vessel is not well opened up, you may have a flow coming down from that side. Once you take a 3 or 3 millimeter stent or 2.75, proximally we have to dilate with a 3.5 millimeter balloon in the proximal part. Then definitely I think antegrade flow will be very good. You can make your comment.
Look forward to. Yeah, no, we look forward to seeing this. I think we've got about 5 minutes left in the live cases before we've got to go back to our didactic lectures. So
you can take, what is the length of the stent?
38.
So what's the stent size that you're going to choose if you're going? Now I believe distally the lumen was about 2.25, right? But EL to EL it was a little bit bigger.
It is actually
and then
2.65 actually, 2.65.
There we go. Okay.
We actually going to take a 2.75 into 38 stent.
Okay.
And this 38, and proximally we will dilate with a 3.5 millimeter balloon. Can you take a 2.75? We are going to take a Synergy 2.75 stent directly after stent.
So the 2.75 Synergy platform will go to 3.5.
Yeah. we can actually make the proximal part 3.5, and actually in the mid part we can dilate 3.5 at a lower pressure, and the proximal part we will go high pressure with 18 or 20, so we get an excellent result, keeping the wire in the circumflex.
I
Dimitri,
think
you had something?
yes, I think one good trick to try and figure out why the flow in the distal LED is not perfect, most likely is as was said by Kumar, that it's a good collateral. You can put a balloon in the right coronary artery and occlude at low pressure the collateral and then take a picture, and that will answer your question. Then you can see the entire LAD or target vessel fill, and then you have no questions whether there is a significant lesion further down or a second occlusion. Correct. Or any complications.
That is one point, Dimitri, but another point is actually you may be pushing down some of the materials which is in the proximal part, and that create a slow flow distally. That is also one possibility we should think about in this case. Can you just come
Absolutely.
to RIO?
So that's sort of where I was going as well with the flip to antegrade, right? Is I often flip my retrograde systems to antegrade, but I keep my retrograde guide in place because I would rather put the balloon up in the antegrade segment towards the distal cap and plug the CTO vessel and take a retrograde injection to prove that you've got a good healthy distal vessel, then do the opposite of instrumenting the donor vessel, because at that point you've got a vessel that's arguably not diseased, and you're instrumenting the non-diseased vessel instead of the one where you're going to end up stenting it anyway.
Yeah, but if you put a small balloon at low pressure, 4 atmospheres, and you occlude the distal flow at the main collateral, you're not going to injure the vessel.
I don't disagree with you. I think the point is that we can always use collateral flow to identify whether or not our distal vessel is good, and that works in either direction. So here, that's interesting, right? So you have a stent up now, and you still have a fair amount of competitive flow distal, which is unusual when you have a totally recovered lumen in the target vessel.
It is possible actually, Sanjog. It may take some more time because actually it was collateralization was wonderful in this case, because you could see that multiple collateralization, even though patient had angina, but the collateralization was very good, right?
So I think this is one of those perfect opportunities where if you had a guide retrograde or in your donor vessel, and you put a balloon up inside that LAD stent and occluded it, you could take a picture and figure out how far that flow comes up. If that flow doesn't come up, then you're dealing with distal embolization or a dissection or something.
We have taken a 3.5 millimeter balloon. Positioning. Ideally, you have to take a clear stent and understand whether we are in the right place.
So, Dr. Pratap, I think at this point we'll maybe switch back briefly to Dr. Kapoor just to see his final result, and then maybe we'll come back to your final result.
If you are coming back, we can show the IVUS last. Okay.
Super.
Okay.
Super.
Thank you. Thank you, Sanjog. Thank you, Dimitri.
Thank you.
Yeah, we can see the IVUS, the distal edge is okay, and here it's a fairly well expanded stent in the distal part.
There is some more expansion required.
Yes, in the mid part we need some more expansion. Here we can see the significant
we dilate to 3.5 only in the proximal part.
And again, you can see that the calcium is causing the eccentric luminal opening. Yeah, again, this is okay. The luminal area is okay.
Can you just go fast and...
Yeah, in proximal part you can see a well expanded stent. Here again, coming back to the ostium, I think it's well covered. Required. It's just covering. There's probably just one strut protruding, and LMC is okay.
So can you show the final angiogram? Can you go to the angiogram?
Go to the angiogram.
This is the final angiogram shot. And can you come back to RIO caudal, and last shot we will show. And we will do some more work in the distal part of the stent and then finish it off. Sanjog, Dimitri.
Wonderful. Thank you very much.
Yeah, thank you for actually we had a
enjoyable.
Thank you.
Enjoyable case to watch.
Thank you, Sanjog. Thank you, Dimitri. Thank you, Aditya Kapoor. Thank you. Bye.
Thanks for having us.
Okay. Thank you for having us. Congratulations on your result.
Thank you. Bye.
Greetings from Fax Foundation, TCT India, South Asia 2021. This live case learnings recording is to highlight the important learnings of a LAD retrograde PCI done by Dr. Pratap Kumar from Mediterranean Hospitals, Kollam, Kerala. The points which we learned here are how to assess the antegrade versus retrograde channels which are seen in these patients of LAD occlusion. And this patient incidentally had a recent inferior MI where the RCA PCI was done outside and attempted LAD which was failed there and was referred for this center for performance of this. But if you carefully watch, there was faint antegrade trickle of flow was also there, but retrograde collaterals also were very good. And Dr. Pratap mentioned, as we wanted to show retrograde PCI technique, he has opted for retrograde PCI, but Dr. Sanjog, Dr. Dimitri, who are involved in large retrograde registries, also felt that if possible, always we should prefer antegrade, because how much ever care, even in expert hands, the retrograde PCI procedures were associated with high complication rate compared to antegrade. But for demonstration sake, though it was used, but always we should try to do the antegrade technique if possible. Then retrograde channels, when you are watching it, and which type of wires, whether it is Fielder XTR or Xeon Black, whichever the types of types of wires are preferable, and also effectively they have to be followed up with microcatheters. Here Caravelle was used basically as a microcatheter after the wire was essentially crossed in from the septals into the LAD and also into the left main. Then Caravelle catheter also could be easily advanced. And one important point to get better support which was highlighted was the distal portion of the retrograde wire should go either into the septal or a large diagonal so as to get enough support for the Caravelle to come into the main vessel. Then later on it was anchored, and then antegrade wire again came crossed into the LAD. And the point of protecting the proximal vessel like LCX antegrade also, even if it is retrograde LAD, was very well highlighted by Dr. Sanjog so as to prevent total collapse sometimes if the distal wire goes into a false channel. So it's always mandatory to protect the proximal another branch vessel antegrade, even if you are doing the other vessel with the retrograde technique. Then after the retrograde wire, then antegrade tracking was done immediately, and then probably balloon dilatations were done. Then intravascular IVUS assessment of the vessel was seen. The distal vessel was something like 2.5, mid portion was about 3, and the proximal portion was 3.5, and the left main was free from disease. That's how after the IVUS assessment of that, they've taken a 2.75 into 38 stent, and then as the distal vessel was smaller, then the mid portion and the proximal portion was again effectively post-dilated. Dr. Dimitri highlighted the aspect of which stent you are taking and what should be the expansion limits of which we should keeping it in mind before we decide to do procedures of post-dilatation. Ideally, probably we could image the vessels pre-procedure and select the stent. But if you're not able to, for some reason of LV dysfunction, hemodynamic instability, if you're not able to image the vessels before, probably we need to take the stent which has a better expansile limits, which can actually have a better apposition and expansion was highlighted. Again, the role of imaging in such patients. Then in the end, the good antegrade vessel flow was established, but still some sort of filling defects and faint disturbances in the flow were seen in the angiography. And the point of whether small microembolism happening through the vessel when we are dilating or some retrograde channel flow still coming were both discussed. And Dimitri mentioned that probably you could occlude the antegrade channels with a low pressure balloon inflation and to assess the antegrade flow, or sometimes you could also do a good antegrade injection to see whether it is microembolism or some minor dissections or because of a competitive flow. We need to assess it well and before we come out. And finally, this patient had good result and with effective demonstration of retrograde PCI. Hope you all like this live case and learned these points. With this, I wish all the best, and this is Dr. A. Srinivas Kumar. Thank you.